a period when one cannot be careful enough in the area of health, with Lassa fever having so far claimed at least 44 persons in the country and coronavirus already recorded in Côte d'Ivoire and Kenya. The government at all levels have been under pressure to protect the borders and prepare the health system in the unlikely case of the virus slipping in. One of the areas for this preparation would be at the grassroots, the level which is supposed to be the first port of call, the primary health care system. What is the state of that in Nigeria?
There are some primary health care centers that they want to take deliveries in the night and they have to use rechargeable lamp. There are no lights or something.
One glaring area of challenge remains not just employing personnel, but retaining them.
How do we source the manpower, we place the manpower, and we retain the manpower?
So let's talk about how best to approach the challenges facing the healthcare system of Nigeria. You're welcome. I'm Ini John Mekwa. The Declaration of Alma Ata, a product of the International Conference on Primary Health Care, which was held in 1978, expressed the need for urgent action by all government, health and development workers, and the world community to protect and promote the health of all people. The conference ended with the general notion that primary health care is the key to attaining this target as part of development in the spirit of social justice. At the primary level, which is the lowest level and entry point to healthcare services, are the health posts and clinics, health centers and comprehensive health centers, providing basic primary care services spanning promotive, preventive, curative, and rehabilitative services. Local government areas own and fund the primary health care facilities and have overall responsibility for this level of care. PHC is the foundation of the national health system. In 1992, Nigeria established the National Primary Health Care Development Agency, and in 2007 merged with the National Program on Immunization to work as a domestic development agency for health. Each state then customized the service through its various boards to suit the peculiarities of its people.
The Primary Care Board is responsible for the planning, budgeting, monitoring, and control of the primary care facilities in Lagos State. The healthcare facilities are divided into three categories. You have the tertiary, which is Lagos State University Teaching Hospital. Then we have 27 general hospitals, which are the secondary facilities. And then we have at the base of that the primary care centers, which is the foundation of the pyramid. Now the facilities are categorized. We have 306. We have 329 facilities spread across different geographical areas in Lagos State. Of these, right now, 306 of them are very functional. Then we have 78 of them as being comprehensive. Comprehensive, we mean those that are working for 24 hours. And out of those 78, 57 of them are categorized our flagship. The 57 according to the local government areas and local government development LCDAs. That's how we come about the 57. Those ones work for 24 hours, 78, 57. The other ones we work from 8 a.m. Till 4 p.m. We have them, like I said, spread over all over the states. Now, we've done an auditing of all these facilities. We have a book regards to that, the current position, that tells us in terms of our human resources need, in terms of infrastructural upgrade, in terms of the services that we are delivering in those areas in terms of what the power need, the audit should be, and also the access to those facilities. It's based on the basis of that the government we are looking at the strategic planning on how to move forward.
The prototype of the structure in Lagos State is similar to that of many states across the country. However, statistics indicate that only about 20% of the 30,000 primary healthcare centers across the country are effective. Most of them lack the capacity to provide essential healthcare services, in addition to having issues such as poor staffing, inadequate equipment, poor distribution of health workers, poor quality of healthcare services, poor condition of infrastructure, and lack of essential drug supply.
Actually, there are health facilities in each of the wards, as far as I know, in Oran. And we get our staff from the Local Government Service Commission because they are the employers for us working at the primary level of health. And the point concerning the personnel is that because of a series of retirements, a lot of people are retiring. And some of us are going to get greener pastures where they can get good offers. And that has really dropped the availability of health personnel generally. I think the thing just cut across all the sets. And the number of staff is really below what it ought to be, because in health, we have a certain number of clients that a nurse should attend to. As it is now, one nurse is attending to has exceeded the number of clients she's supposed to attend to at any given point in time.
Well, government can still assist us more in the area of electricity. At times when the electricity have problem like that, we spend more money buying fuel. But if the electricity problem is not there, like this Lagos State electricity something, we have 24 hours running. Like the former place I work in, a comprehensive health center, Lagos Island, they have their light 24 hours. So we want something like that in this place also. Electricity, and some of our examination room, we want the place to be more conducive, like providing us with AC. We want the fans to be functioning properly.
You got in here the poor electricity supply, the road network, then the equipment to work with at times. You really don't have everything that you need. Even when you were trained, you were trained with everything, and you got there. There are times, well, it doesn't happen here. There are some primary healthcare centers that they want to take deliveries in the night, and they have to use rechargeable lamp. There are no lights or something. But that's no longer happening in Lagos State again.
The Akwa Ibom State government says that its healthcare facilities are receiving a facelift in the area with the intervention of the federal government.
Our state, the House of Assembly in the state has passed a bill after the first and second reading and the public hearing. They passed a bill which His Excellency, the Executive Governor of Akwa Ibom State, immediately signed into law. So as we speak now, the federal government is handling a lot of activities, refurbishing, reconstruction, the running of the primary health care. There is a board by the state. That law makes it mandatory to have a board. Government has instituted a board, Primary Healthcare Development Agency Board, which is running that. They are just about having a committee, migrating committee, to take it from the local government service commission into this primary healthcare development agency. So they are doing a lot already. A lot of money has been voted, and they're reconstructing perimeter fences where they didn't exist, reconstructing the buildings themselves where they had collapsed, putting water where there was no water in those services.
9 years after the National Primary Health Care Development Agency was birthed, there was the Abuja Declaration. This was a consensus by the African Union countries to set a target of allocating at least 15% of their annual budget to improve the health sector. Almost 20 years later, the federal government has allocated 46 billion naira for capital expenditure for 2020 and 44.5 billion naira for the Basic Healthcare Provision Fund. This is just about 4% of the budget. This insufficient funding and ineffectiveness directly affects the country's maternal-mortality ratio, as it's almost as if the primary health centers were made for just women and children. According to World Bank data, the fertility rate for Nigeria in 2019 was 5.349 births per woman, a 1.26% decline from 2018, and there's high infant mortality of 74.09 deaths per 1,000 births. With this high level of interactions, healthcare givers are able to observe and highlight issues which may have been unidentified before now.
The data were not too keen, but we have as much as 19.8% of mothers coming up with mental illnesses. And that's because I believe that, you're expected to know what it is when you're pregnant. You're expected to just fall into the role of being a mother. No support structure properly. You may have family support, but you don't have the right family support. So this is things we want to do. We want to come in where it is coming from, even the point of the health workers, to help reduce this as much as possible. With health, your primary contact is with the health workers when it comes to your health. You go to your nurses, you go to your doctors. So I believe if we get them with information on how to manage mental illnesses, they know what to do. That is why the first point of contact, train the health workers on even recognizing when someone has a mental illness, and then we can take it up from there. So that's why we started with the health workers. Now, the health workers in particular are the nurses, because we have come to the primary health care. And the truth is we have a lot of people that access care in the primary health care places. Primary health care centers are delivering basic, when I mean basic health care, but antenatal services also come under basic health care.
What we are doing is, anytime a mother walks into a primary health care center, she should at least be able to have access to a maternal mental health intervention, whether she's coming in for postpartum support care, whether she's coming in for pregnancy, which is the antenatal, or whether she's coming in for family plan and she's preparing for another baby. So the care that is in place is to make sure that, this mother is mentally healthy, she's stable. So if there is in any case, a mother who is not mentally healthy, who is not mentally stable, you identify them, you pick them, and you give them back to us. We have our clinical instructors who would, have sessions with them and, pick out their genuine needs, and then we administer those care. So for example, a mother who is preparing to get pregnant and she's probably not ready and she feels there's something wrong with her, and then we have identified that she's not ready. And then we identified some of the things that she said that, that she said that we'll know, okay, these are the things that is making her not to be ready. From there, we'll pick her up, we'll advise her on what to do, and the fact that the society doesn't need to put pressure on her. If she's not ready, she needs to do this. If she's, let's say if she's diabetic, if she's hypertensive, we need to tell her, okay, you need to do this and do that, so that you can be healthy enough to carry a baby for full term.
The healthcare givers have to be properly equipped to carry out this work. There's been talks of inadequate or insufficient staff to transfer the needs to the patients, from attitude to required skills to make the primary health care centers fill the vacuum.
I think they work under immense pressure. They work in environments that are not totally as conducive. Do you understand? And I feel with that, you're tending to I'm sure if you come for the antenatal clinic, I'm not trying to make excuses for them, but if you're seeing over 100 patients, the time you want to get your job as fast, you want to get your job done as fast as possible. So your time with every patient, you're as time conscious as all. That's why we had looked at it in a holistic thing, trying to give highlighted points. So you do your checkpoints. So they're like a checkpoints that you do. You do your vitals. From your vitals, you talk with the patients, and with your questionnaire, you can identify some things. I'm not trying to say that, it's an excuse, but Generally, we're not warm people. That's the honest truth. Africans, if I may say, we're not very warm, we're not very sociable. So sometimes it may be lost in the process of working under so much pressure for you to now be empathic.
Lagos State government seems to have developed a system which may be dealing with filling the personnel need in the centers.
There's one good thing about Lagos State. There's this plan called exit replacements. So once they retire, there's replacements. So now, I think about last week or 2 weeks ago, there's this information that is out that Lagos State is set to employ more health workers to replace those that retired, maybe sometimes last year. So we want to replace them. So last year, quite a large number of health workers were employed by Lagos State too.
Dr. OKIKIOLA has a proposal which could solve the challenge of number and spread of staff in the healthcare centers, especially in the rural sites.
It's not enough that you are producing these people. You need to engage them actively. How do you engage them? You need to actually have a big program. How do we source the manpower, we place the manpower, and we retain the manpower? It is that retention bit that we always get wrong. We never place emphasis on the retention of health workers. I see no reason why most of all those people will not stay if we decided to think outside the box. I give you a very good example. There was something that was proposed. They found out that quite a number of women were dying from lack of the presence of skilled birth attendants. So what did they do? They contracted retired nurses, midwives, and said, okay, we want you to come back into the system, we want you to come and help and all. Now, what did they do wrong? This was a concept we copied from elsewhere. We copied from Asia. It worked well. Now, the difference, where we got it wrong was the fact that you recruit somebody in Lagos, for instance, a retired nurse in Lagos, you post the person to Abeokuta, or you post the person as far as Kaduna. The person going to Kaduna needs accommodation, needs remuneration. Now, the arrangement was the federal government will pay a percentage, the state governments will pay a percentage. The state government and the local governments were to provide accommodation. So what do you find? The person goes to that state, goes to the community. One, the person is a stranger in that community. Secondly, the person is not really well settled in the place. Third, the remuneration typically are not forthcoming. So what do you find? Those people don't stay, but on paper, that person has already been employed and deployed. On the whole, it has not really impacted in the reduction of maternal deaths from lack of skilled attendants at birth. If we decide and say we want to use this, the people who are engaged should be from that locality. If you pick from amongst the people and you say, okay, you live here, you are a son or daughter of the soil, this is what we need you to do. One, the people that are familiar with that person. The person is familiar with the people, is familiar with the terrain, familiar with their cultures. Unlike if you're bringing somebody from outside. You're familiar with their cultures, familiar with everything. The tendency is those people will stay. Now, this is where the gaps that exist in nature, vacuum does not exist for long. It gets filled up. This is where the quacks tend to then fill in because the quacks will stay.
These issues have largely contributed to the annual resurfacing of ailments like Lassa fever, which has shown a predictable cycle which ought to have been curbed by now.
What we have stepped up is surveillance, which is continuous monitoring and picking up of the cases. So where easily we can say there's a case in Ondo State, there's another case here, there's another case here, and that's coming up a little more. So it maybe looks like it's more now. But we're getting on better with surveillance and being able to push out the information outside that there's Lassa fever. But in terms of our personal hygiene, environmental control, and all other kinds of policies that can help to put a stem to Lassa fever, I'm not sure we're there yet. Again, it's a lot of political will towards the health sector, because at every time in the year, we find that Lassa fever outbreak occurs. And so we need to then commit a lot more, especially to funding in research. When a problem is not global, as it were, it's unlikely that funding to that problem will be heightened. So when it is a problem, we should then be ready to fund more research into those areas that can, for instance, produce a vaccine or build up our laboratories and make the detection easier. So we find that even when you have a suspected case, what you just see is that it's a suspected case, and then you have to take the samples and send it to a designated lab. And in some geopolitical zones, you may not have more than one of those labs, or you may need to cross to another to send it there. Before the samples come back and says, yes, it is, it continues to spread. So these are issues we'll need to commit more in terms of the will to, the funding, the research, and everything that it takes. And of course, we won't stop the awareness. But again, when you keep giving awareness, people's perceptions are different. It's very difficult to change that, to change people's attitude. It's the last thing you want to do. So rather than, harping on change the attitude and all, you can do other things that will prevent it. And that's why vaccines are one of the most cost-effective ways of dealing with issues like this. So the Ministry of Health really does have some federal parastatals that are into on what they are producing a vaccine against. In some cases, you give a dose and it's a lifetime protection. But in some other cases, you find that irrespective of what you try to do, the virus, the organism keeps changing, and so you cannot keep changing vaccines for it, and it's difficult, but not impossible. So research, a lot is going on, but can it be more focused, more targeted? The willingness that let's get to the bottom of it. It may need us, of course, collaborating with institutions that are far more advanced in terms of technology and all of that. But yes, it's doable. And a lot of other diseases like malaria and co, they're already working on things like vaccines towards it. But we need to spread it to other diseases. I mean, the coronavirus that hit China is the first of its kind in humans. It had been affecting animals, but not humans. And, the article said that they were ready to build a treatment center in 10 days that could take 1,000 beds in 10 days. And we did see pictures of them clearing the place. So that is saying that it's going bad, but what ways can we stem it? So while already treating those that are sick, they go straight into the laboratory, and I'm sure they're going to be looking at how they can prevent it. So we will not arrive there in one day, but from funding, it shows where we are going.
Health is wealth. So whatever it costs to keep the people healthy is always worth it. And of course, whatever it costs you to stay healthy, please embrace it. And sometimes it may just be staying informed, not necessarily financial. Don't forget to stay in touch with Big Story always. We always want to hear from you. That's it. I'm Ini John McQuan.